Welcome. My name is Gina Curry, and I am the Director of the Office of Community Engagement and Cancer Health Equity at the University of Chicago Medicine Comprehensive Cancer Center. And I am pleased today to have our guest, Dr. Hlubocky, who will be talking about caregiver and research that she's been doing at the University of Chicago Medicine. Just a little background on Caregiver Awareness Month. It was a month that was established back in the Clinton administration. Actually, it was a week-long recognition of caregivers, and then in the Obama administration, it was changed to a month-long observation. So we are excited to just talk about caregiver and caregiver support as we are community facing, and many times we're talking to our partners about some of the struggles and the joys of being able to provide care to their loved ones. So I'm going to read a little brief bio about Dr. Hlubocky today, and then we're going to start our conversation. Dr. Fay Hlubocky is a licensed clinical health psychologist specializing in psycho-oncology and an ethicist at the University of Chicago Medicine in the Department of Medicine, section of Hematology, Oncology, Supportive Oncology Program, and the McLean Center for Clinical Medical Ethics. Her clinical research and educational efforts center on the impact of the psychosocial and ethical concerns in cancer care involving patients and caregivers across the cancer trajectory, including decision-making, distress, quality of life, survivorship, couples reported outcomes, disparities, spirituality, supportive care, and physician-patient communication. Dr. Hlubocky also is a curriculum director for Fellow Talk, a program designed to improve communication between cancer clinicians, patients, and families. She has presented at several national and international conferences on research and educational efforts to enhance awareness of addressing patient and caregiver psychosocial needs across the cancer trajectory. Finally, Dr. Hlubocky serves as a committee member, leader, and advocate to the Alliance for Clinical Trials in Oncology, American Society for Clinical Oncology, and the American Psychosocial Oncology Society. So without further ado, we'll go ahead and start the discussion. Welcome.
Oh, thank you. So delighted to be here with all of you. Such an honor and a pleasure.
Thank you again for joining us today, Dr. Hlubocky. My name is Aaliyah Poulos, and I am an Education Outreach Special at the University of Chicago Medicine Comprehensive Cancer Center in the Office of Community Engagement and Cancer Health Equity. I'll be helping to facilitate today's session. So Gina's already given us part of your very impressive bio, Dr. Hlubocky. If you could just give us a little bit more information about your education and research, particularly your research on spousal caregivers, as well as if there are any current caregiver research and studies going on that you are currently a part of.
Oh, thank you. It would be a pleasure. So I'm a psycho-oncologist, a clinical psychologist that has training, not just in psychology, but specializes in the mental health aspects and psychosocial aspects related to cancer. So care of cancer patients and caregivers, and also cancer clinicians. A lot of that also involves research and education to clinicians about what cancer patients and caregivers are going through. I've had a long time interest in caregivers of cancer patients because this can tend to be a forgotten population. We very much focus on the patient, which is vital, but we have to recognize that the cancer caregiver, it goes through a great deal. There's a lot of psychosocial concerns, a lot of emotional health and physical health issues that we have to address. So it's vitally important examining the issues associated with caregiving and what the caregiver is going through, both from a couple's perspective as a spousal caregiver, but there's also the family caregiver, the sibling, the child that's taking care of that cancer patient. So vitally important to address their needs and to provide interventions as much as we can at any part in the cancer trajectory. So from a time of diagnosis to end of life, and also long-time survivorship, very important, because we know if the caregiver is doing well and is supported, that ultimately improves the quality of the patient care and the doctor-patient relationship overall. So I've had an interest ever since training, leading caregiver groups, bone marrow transplant caregivers, and across my training, always have seen caregivers in the context of therapy and research and education. Again, providing education, especially to our trainees, about the importance of providing empathic support to caregivers as well. So my dissertation was on cancer couples in clinical trials, as well as we've done some more work looking at narratives and really trying to identify the experience at the end of life. On the other spectrum, also working in the field of gynecologic oncology and looking at the ovarian cancer survivors, caregiver as well, looking at their quality of life, examining their experience. Just when cancer treatment has ended, it doesn't necessarily mean that distress or that needs have ended. Again, it's vitally important for us to support this caregiver even in survivorship. So checking in, seeing how that caregiver is doing, again, can improve the quality of even survivorship care. So we're doing some research with the National Ovarian Cancer Coalition, assessing caregivers' quality of life and other psychosocial outcomes through a web-based survey. So that's very exciting. We recently completed a study with the Alliance for Clinical Trials, a well-known trial examining the quality of life and the distress of cancer patients receiving concurrent palliative and cancer care, standard cancer care. That actually also included the experience of the caregiver and longitudinally following them out. So data is still under analysis there. So lots of different projects, again, across the cancer trajectory, because the caregiver is important. So it's such an honor and a pleasure and a humbling experience to serve our cancer caregivers and to honor them this month.
You made a really good point about just that, that psychosocial support needed by so many caregivers. I was just in the community with a husband, and you're talking about that spousal caregiver. I was just in the community and I was talking to a gentleman. He was a caregiver for his wife, and ironically, it was his wife has a gynecologic cancer. He was talking about just how he feels so helpless, and that he wants to remain strong for her, and he puts on the front, even in front of their children and that kind of thing. But you're right, there's so many, it's such a psychological and emotional journey, and particularly for men, sometimes they don't always have that, that the same maybe feelings of showing vulnerability or that kind of thing. Did you see any of that kind of thing in your research, or any kind of thing around like disparities in caregiving, and as it pertains maybe to even men, or racial?
Yes, absolutely. We know that males generally tend to not externalize feelings as often. Again, not to be stereotype, everybody is very different and individual, but they tend to try to be the hero, the person that can take care of not just the patient, but the family. But the burdens can be significant because it's taking care of the patient, especially in active treatment, all the needs, the billing, the basic needs, the physical, the emotional needs of that cancer caregiver. So a lot of folks have described it as being on automatic pilot. I'm just going. There's no switch to really turn off to evaluate one's feelings. Just how are you feeling physically? How are you feeling emotionally? A lot of our research has shown that there is a lot of anxiety that can occur, especially with advanced cancer patient caregivers as well. And it's really important, as well as physical, that quality of life, that ability to be mobile, to feel have physically well-being, to be functional. We know that can be impacted, and our data has actually shown that. So again, it's about empowering. It's taking this data, but making it real so that we can apply this data to learn from it and apply it to interventions. And that's why we're thinking more of not just caring for the patient, vitally important, but to include that caregiver. I know when I have worked with caregiver groups, and that a lot of the times it's very difficult to externalize these feelings, to externalize what they're going through, because they don't want to take away from the cancer patient experience. They don't want to, quote unquote, feel selfish, but not at all. We need to know what you are going through, because ultimately, if that caregiver, if you as a caregiver are feeling well, then that patient, again, the patient will do ultimately better from that kind of quality of life perspective, because you are able to take care of them. So absolutely, there are disparity issues, and maybe I can share some of the slides for the data to talk a little bit more about what we found in our research. So again, such an honor to be talking to you today and to talk about November is the National Caregivers Month, as Gina had described. So it's really important, and it's wonderful to be able to honor you as the cancer caregiver and the clinician to the cancer patient and to the caregiver. Who is the caregiver is, oops, sorry. See that? Okay. The cancer caregiver is actually called the informal caregiver, the unpaid individual, for example, that spouse, that partner, that family member, friend that's involved in assisting others with activities of daily living or medical care. So that can involve family, it can involve friends, it might involve community members, church community members, for example, and the formal versus different. So again, this month is really honoring that informal caregiver, that family caregiver. The formal caregivers are those paid providers. So that could be in the care setting, but it can also be your physician, your nurse, folks in the medical community. So there's that distinction. Caregivers in the United States, generally, we know there's about 43.5 million caregivers that have provided unpaid care for an adult or child. 34.2 million Americans have provided unpaid care to an adult aged 50 or older. The majority of these caregivers care for another adult, while 15% actually care for two adults. Or and there's also statistics on 3 or more adults from the National Alliance for Caregiving and the AARP. Approximately 38, almost 40 million caregivers provide care to adults 18 and older with those with a disability, or 16.6% of Americans. And about 15 million adult caregivers care for somebody who has Alzheimer's disease or another dementia. In cancer, of course, the cancer caregiver, this is data from the National Cancer Institute that was presented, but it was actually a study, a 2016 study of 110 caregivers that was conducted by a subset of a larger study, but from the National Alliance for Caregivers. So again, 4 million cancer caregivers in the United States, that represents 8% of all caregivers. 58% are females, have been self-identified as females in this study, and that average age is 53 years. So that's 4 years older than non-cancer caregivers. Again, cancer has been viewed as a disease of the elderly, but we know that it can impact folks from across the age spectrum. And the average role of the cancer caregiver is 2 years, and that usually includes time of diagnosis throughout treatment. And that non-cancer caregiver averages anywhere about 4 years. These cancer caregivers report high burdens, more caregiving hours, and actually 41 hours per week, which is equivalent to a full-time job. Isn't that amazing? And I know many times when I've met caregivers, that's what they say, that this is my full-time job. You know, I really am thinking about and the fact they might actually have a true paid job. Those unpaid caregiver services is about $500 billion annually, and it surpassed paid caregiver services in 2013.
And I just wanted to mention, since you're on this slide here, I mean, just the like the average age is 53, and just like the gentleman I was talking about, you know, he was up in age and he had his own health concerns that he was dealing with, but he wasn't retirement age. So as you mentioned, he's still working a job, and then 41 hours. That's, that's again, like 2 full-time jobs of, caring for a loved one, and you're already managing maybe your own chronic disease. So it's very important that we support our caregivers as much as possible. These are incredible stats.
That statistics alone is sobering, and if that's not data for advocacy, I don't know then what is. That the importance of truly taking care of our cancer caregivers excuse me, across the a trajectory. And again, who's the caregiver? That's the spouse. That tends to be the family member. And there's a whole host of studies that's been done in oncology. But some of those studies have revealed that 70% tend to be the spouse, 20% tend to be the child, but have been identified as primarily the daughter or the in-laws, if it is a patient that has in-laws. And then there is this 10% that's the friend, or what's called the fictive kin or cousin in various different cultures. And that I come from a very Eastern European culture. My mom's friends are aunt and uncle, and those are also, people that we have to consider when it comes to the cancer patient and the cancer caregiver. So just to recognize that 10% is a friend of the family, not necessarily a non-blood relative. It could also be a church member, a chaplain as well. We've identified that in some of our studies. 38% of these caregivers in one study by Brown et al. In the Ferguson work reported symptoms that actually met criteria for a psychiatric disorder, depression, or anxiety using the former DSM-4. And the caregiver tends to aid that, especially in the advanced care setting, but it's across the cancer trajectory in decision-making pertaining to treatment, right? So that's at end of life. That also could be at survivorship when they're coming in for monitoring of their cancer and their survivorship status. And they become, especially at end of life, they become that proxy decision maker, having to decide if that patient is DNR or other kind of advanced directives. Quite a burden, quite a difficult cognitive burden that they have to undergo. That partner undergoes a significant adjustment. There's a lot of family and occupational changes. So although a lot of caregivers tend to be older, the younger caregivers, for example, in breast cancer, younger male counterparts have been found to have to take up more child responsibilities and occupational changes. Many do still work full time, but try to negotiate. If they can't take family leave, maybe will take their break at lunch and try to bring the patient into to the hospital for their appointment. So these are these kind of anecdotal experiences that have been identified in the literature. Again, significant financial burden, lack of support. We also found out that despite the fact that that caregiver might be working, there are still financial burdens that can be experienced, and a lack of social support. Again, that as Gina had mentioned, that gentleman that might not want to ask for support or feels like he has to take everything on for himself. We know that social support is incredibly important when it generally comes to quality of life, but caregivers tend to be scared to ask for help. That quality of life is diminished, right? So it's that physical, that social, that emotional well-being, that functional well-being, just being able to get up and get out of bed. Again, automatic pilot, but we've heard of caregivers having, again, comorbid issues, having to deal with their own illnesses, as well as sometimes emergencies happen from those stressors where caregivers themselves sadly would have to be hospitalized. So vitally important that we support them. They tend to access medical and mental health services more frequently than other cancer caregiver population, and a significant amount can experience symptoms associated with post-traumatic stress, again, the trauma of cancer, and that not again diagnosing, but just symptoms related to. There is also some preliminary research that shows that there's a lot of post-traumatic growth that you can actually find meaning and purpose beyond this cancer caregiver experience on that, but very preliminary findings. In our own work, this is now a publication that is just in press in the Journal of Clinical Oncology Practice. Again, this is the advanced cancer patient that was enrolling in clinical trials, phase 1 clinical trials, where really the goal is to look at the dosage and toxicity of the treatment. There is no really hope for a therapeutic benefit. But despite that, a lot of these patients do hope to receive some type of therapeutic benefit despite this terminal disease and these symptom burdens. So we looked at these associations between the symptom burdens that both the cancer patient as well as the spousal caregiver specifically were experiencing potentially, and what were their expectations that this trial was really going to work for that cancer patient on a phase 1 trial. So we looked at these dyads and assessed them at the time of enrollment of a phase 1 trial, and then 1 month later using well-validated measures of depression and state anxiety and quality of life and post-traumatic coping and marital adjustment. And then had some interviews that examined their experiences and their expectations of benefit going on these trials. And so it was 52 couples that we had separately assessed and interviewed. And as you can see, the median age there is 61 years, primarily the patients. For the total population, this tended to be mostly a male patient population, and the spousal caregivers were more female. But for the cohort at all, it was 51% male, 100% married, 87% Caucasian, and 41% greater than or equal to a college education. And what was a lot amazing was that anxiety, no matter what statistic we did, really just kind of blew up there and was lit up and said that this was a significant predictor for any kind of expectation associated with trial success and stabilizing the cancer, shrinking the cancer, remission of the cancer. So, and that state anxiety is that anxiety in the present moment, and that versus a trait anxiety, which is kind of your anxiety overall, your traditional anxiety. So those regression analysis had then further revealed negative associations between these expectations for stabilization and state anxiety and trait. Quality of life was also considered negatively associated with expectations of benefit. So, so we recognized that overall that anxiety very much impacted those couples' beliefs regarding the likelihood of benefit. And it's important for us to know that because that can impact the decision making when it comes to quality of life of receiving palliative care or hospice. So again, even though this is an advanced cancer setting, it is also important for us to recognize that mood or distress can impact the patient and the caregiver at any point in time across the cancer trajectory. This was a narrative interview, so allowing the cancer patient, again, going into the trial, and their spouse, again, to tell us their story and their thoughts of their understanding of prognosis in phase 1 trials. Again, the notion is that if you have an understanding of your prognosis, that you can receive quality end of life care. But again, many of these patients have opted to receive clinical trials as an attempt at the end of life. And these clinical trials, again, we are only testing the drug safety and dosage. So despite this terminal illness, that prior research has shown that advanced cancer patients overestimates their survival, provide little acknowledgement about the prognosis, and very much desire cure as a goal. So this research might not accurately reflect prognostic awareness. Does that really reflect what their doctor told them with, time frames or the status of their cancer, and how hope actually affects these measured responses if they will die. So these observational experiences were very important. So really allowing that patient and the caregiver to tell the story through what's called narrative analysis on emotion. So again, that was 28 terminally ill cancer patients and couples couples overall, and very similar demographics as you've seen before, because that's the phase 1 patient population at our institution. But their quantitative interview data also looked at stabilization and halting and that. But these narrative analysis, what was most important, revealed that in all of the pairs, there was a lack of a terminal a lack of an acknowledgement of a terminal prognosis. That is that they will ultimately die of the cancer. Many did not describe the physician disclosure of the prognosis. Many of the acknowledgements came outside of specific queries about this prognosis understanding. So maybe, reading the internet or that this is where they felt like they understood or gained that information from that. And again, recognizing that there was depressed mood with the study, we recognized that their depressed mood was apparent with greater changes in thinking about the value of life. So again, what meaning and purpose. And while in response to these queries, we know that there are significant expectations as in the prior, inaccurate estimates of survival, and that we need to really understand this illness experience to be able to better communicate the nature of disease, patient's prognostic understanding, again, to provide the best quality end-of-life care. When we talk about racial variation in cancer caregiving, there's been a whole host of studies looking at this across the cancer trajectory, but this was one of the best studies out there that examines what the cancer caregiver is going through. We know that racial disparities are present across the cancer trajectory. Little is known about what exists in informal support. This is a study that was the large of this really kind of multi-institutional project of multi-site care recipients, and examined the caregiving experiences of African American and white caregivers. And the intervention was just to complete self-administered mailed surveys, very similar to ours, about their experiences and characteristics during the cancer trajectory. You'll see the statistics there. In yellow, it's highlighted that despite greater preparedness for the caregiving role, African American caregivers reported more weekly hours caregiving than whites. A significant difference of 26.5 hours versus 18 hours. And in later phases of caregiving, the African Americans actually reported more social support, more hours caregiving, and performing more instrumental activities of daily living on behalf of their care recipient. So it's important to recognize that racial disparities in caregiving do exist, and that in our care for caregivers that we need to really focus on the individual, to identify with a really good needs assessment, in educating cancer patients and their caregivers how to cope with and manage cancer. And that for African American caregivers, and particularly because they spend more time in caregiving, they perform more caregiving tasks, that maybe nursing or other kind of psychological interventions tailored specifically in addition to what they're doing to their specific caregiving experience. So that was one of the best studies that has been done recently by Martin and colleagues to really, for us to understand the disparity. When it comes to cancer caregiving now during the COVID outbreak, the data is very preliminary, but we know from anecdotal reports from our oncology colleagues, as well as patients and caregivers, that we know it's become, of course, a more serious experience right now. Patients with cancer, because they tend to be older, they tend to have more comorbid symptoms aside from the cancer and comorbid conditions, and they are immune compromised. So it's vital, as reported by the American Cancer Society, that staying healthy really protects the cancer caregiver and the patient from the virus, and that means taking some extra steps. So who is at risk when it comes to that cancer patient who might be at risk for COVID? Those with lymphomas and multiple myelomas and leukemias, those that just completed surgery, those in active treatment, those that have had stem cell treatment, bone marrow transplants. Again, because that immune system is weakened, they tend to be at a greater risk for infection. So the ACS gives some recommendations there about washing hands frequently, making sure that there's only one caregiver often, seeing the MD as frequently as possible, and restricting visitors. However, this can become a very lonely experience. Already cancer caregivers are experiencing significant emotional and physical burdens. They lack social support, and now we're isolating them even further. They're feeling more isolated, they're feeling more lonely because there is this greater risk to the patient and to themselves, and the fear that them just even going to the grocery store, for example, or picking up their medication, if it's not mailed in, that they could bring the virus home to the patient. And that we are hearing that from our colleagues across the country. So again, even more important for us to be able to provide that support at our institutions, of course, and really across the country to recognize the fact that these caregivers do need the support. So what can they do? And these are some great strategies for enhancing caregiver well-being that the cancer support community has provided, is finding that support system, and especially now virtually. We might be sick of Zoom, we might be sick of telephone calls, but trying to tap in, managing it, monitoring it as much as you can, to connect with somebody as much as you can, especially now during the COVID experience that we're going through, gathering that information for the caregiver. Knowledge is always power. Always, trying to gather as much information as you can from sources. Being careful of the internet, because they can provide some false information at times, because it very much of the information has to be individualized. But really relying on the team, your oncology team. Knowledge is power. Recognizing this is a new normal. This is something I always tell cancer patients or caregivers. This is a new normal. It's a strategy to help you to manage the loss of control that we can experience during cancer caregiving. It's relieving your mind, it's recharging the body, taking time for self. And the caregiver has such a hard time to do that, right? Because you're on 24/7. But vitally important to just take even 10, 15 minutes of having that coffee, maybe when that patient is sleeping, being able to go outside in your yard if that's a possibility. Maybe just making a room, in a corner in your room for meditation, someplace where you can go, where you can find relief. Just even looking outside the window, we know that those type of things can be refreshing. Taking comfort in others, again, relying on social support. It's the only gift your family members can give you. So taking comfort in the support of others. Planning for the future, vitally important when it comes to finances, as well as end-of-life care. Accepting a helping hand, again, that the role of social support, it's resonating. We're repeating it because it's so important. Being mindful of your own health. It's so tough to get sleep, to eat well, to exercise, but trying to incorporate little strategies during the caregiver and COVID experience right now. We know in hospitals, so many times the caregivers would be sleeping there 24/7 and just utterly fatigued. So many times encouraging that caregiver to just go home, maybe get a cup of coffee, or even going home to do the laundry, just to be able to change that physical environment around, to be able to refresh, much less actually gathering sleep and those important critical resources for health. And again, exploring stress management techniques. Do what you can, admit what you can't. No one can do everything. It's okay to ask for help. Please ask for help. You will empower yourself. You will not weaken yourself. You can only empower yourself by asking for help. And that. So again, meditation is one of these techniques that we always talk about, and folks ask, gosh, how do I meditate? Sometimes it's sitting still, but really meditation can occur at any point in time. It's just being still. It's even watching television and learning to relax. It's a process. You surrender. It can be a very beautiful thing. Paying attention to nothing in particular, simply being awake and focusing on the breath, letting that happiness in that moment. Again, the caregiver experience is such a challenging experience, but being able to find moments of calm and peace and happiness and serenity is vitally important to both of you as a dyad. Mindfulness is a great approach. I'm a huge advocate of folks trying to learn this as an approach, because it's really just paying attention in a particular way. You can do it's on purpose, it's in that present moment, and you're being non-judgmental. So thoughts may come and go as you attempt to breathe, but that's okay. Just recognize that thought and focusing on your breathing. We know that cleansing breaths tend to get rid of that carbon dioxide in the body and only brings in oxygen, which helps our health overall. So many actions are just breathing, taking a moment to appropriately breathe from that stomach, exhaling from the mouth or the nostrils as possible. Walking, mindful walking. We never think about stepping and on and providing, that when you're feeling overwhelmed, actually pressing your feet against that floor. That helps us to establish a very strong foundation to engage the five senses. Always becoming inquisitive when you feel frustrated with the physician potentially, or maybe your family member, or maybe your colleague. Don't ever argue. Always ask questions. By being inquisitive and using inquiry, we can uncover new ways of surpassing those roadblocks, even when it comes to decision making for treatment, for example, for the patient. And then naming the mood, externalizing, getting that emotion off. I feel sad, I feel angry, I feel happy, maybe just in this moment. It just is a way to put your feelings in perspective. And a strategy, which sounds illogical, but maybe every hour, or at least 3 times a day, writing down one word that summarizes your state of mind. And I even tell folks, just naming your mood. I feel sad just this moment can really help when it comes to our overall well-being. And then using some visual techniques of just, letting it go before you leave the hospital, before the day's end, prior to going to sleep. Imagine a box and just placing all the day's events, good or bad, visualize it floating away and starting anew the next day. Again, it's about peace, it's about serenity, it's about your well-being as a caregiver, and for the oncology team to recognize the importance, to applaud the caregiver in their care of the patient, recognizing that this is a very challenging time. Again, being empathic is vitally important. Lots of resources. The National Cancer Institute actually has a great free PDF, the support for caregivers. You can just get it online. The cancer community support groups are wonderful. Gilda's Club, now everything is virtual. So they actually have a caregiver support, both Gilda's and Wellness House, that you can access. Again, all the support there is free. It is virtual. That can be a challenge for many of our folks that might not have access to the internet. So coming into, say, the University of Chicago and coming into the support of oncology and calling, asking your doctor to call for supportive care. We are here for you with social work and palliative care and psychology and psychiatry and physical therapy. We're there to help not just the patient, but the caregiver, and especially when it comes to financial stressors as well, to provide additional resources are here. Again, you can access any of the cancer support organizations, including, again, a lot of the services now are free. But even just calling, if you don't have access to the internet, if you have a phone, just calling up. I know a lot of these places are trying to accommodate patients and family members as much as possible. And our psycho-oncology providers, this is a national hotline that you can identify any kind of cancer clinician across the country. So thank you.
That was excellent. Thank you so much, especially the resources at the end. I mean, the entire presentation was phenomenal, but thank you so much. Those resources, when we are able to share this video with our caregivers in the community, this is going to be excellent to help them. And I mean, I love mindfulness too. So yeah. I love that slide particularly.
I'm so glad. Again, it's such an easy technique, and we're here for you, caregivers. Please don't be bashful to ask for help. I know so many times when caregivers have finally relented and asked for help, they just feel so much better. That again, the team is here not just for your loved one, but for you. We really want to help you. We know that the burden is great. and we want to help you shoulder a bit of that.
So, Dr. Hlubocky, thank you again for all that amazing information. Wow, that was a lot, and we're really excited to be able to share so many great tools and resources with the caregivers that we know in our communities. If you had any sort of, if one big takeaway from this video for caregivers who may be watching, what would it be?
One big takeaway, we are here for you. We know that this is a very challenging time. We are partnering with you. We are here for you. We hear you. We are with you physically, emotionally. Please, at any point in time, reach out. At this moment, it might not feel like it will be better, but it can be. And we are here to help you, to help improve your emotional and your physical well-being during this really tough time.
Great. I think those are really important words to share. As you mentioned, the care of the caregiver sometimes gets pushed aside in favor of the patient because that's where all the focus is. And it's really important that we stop and recognize the needs of our cancer caregivers as much as the patients. They're an equally they play an equally important role in cancer care for sure.
Yeah, and we are so grateful to you. We are so grateful. You are so resilient. You are a role model to all of us caregivers. But truly, you can't do it alone. And it is okay. There's no shame in asking for help and support. And we're here to do that. We're here to do that. I even tell our fellows, training our fellows, saying check in with that caregiver. It's vitally important for us as a team, but especially for you. If you feel like you need that help, please know that we're here for you.
Great. Well, thank you again to Dr. Hlubocky for sharing your wisdom and data and all your research and just all the really great resources that you've provided for cancer caregivers. And we hope that some people watching this video will certainly take a moment to realize the important role that they play and the care that they need and take advantage of some of those resources.
Yeah, thank you. It's such an honor and a pleasure to be with you all. Happy National Family Caregivers Month. My thoughts and prayers are with you all. Thank you.
Thank you.
Thank you.